Okay, so tonight's program, BRCA-positive early stage breast cancer, the update on the treatment and the implications for testing. Our speaker tonight is Dr. Reshma Matani, who's the Chief of Breast Medical Oncology down at Miami Cancer Institute in Miami. Several of you submitted some great cases for discussion, and I look forward to getting to that point. Reshma, I'm going to go ahead and let you begin.
So, as mentioned, we'll be focusing on BRCA-positive early stage breast cancer treatment and testing this evening. My name is Reshma Matani. I am a medical oncologist. I specialize in the treatment of breast cancer, and I lead the breast cancer program here at Miami Cancer Institute, which is part of Baptist Health South Florida. So, when we talk about this topic, the first thing, of course, is to talk about which patients should undergo germline testing in 2023. And I'll have to say that this is something that constantly is being discussed and rediscussed, as we now have a treatment that is a very targeted treatment for a group of patients that have a germline mutation in BRCA. We'll spend some time going through a very important pivotal trial that led to the approval of our first adjuvant PARP inhibitor, olaparib, for high-risk early-stage HER2-negative patients with a germline BRCA mutation. And I'll put this data in context with our other treatments for high-risk patients, specifically pembrolizumab, as we're using now a neoadjuvant and adjuvant IO therapy for our triple-negative patients. Of course, we have data to support using capecitabine in patients with TNBC that have residual disease. And finally, now, we also have very good outcome data with a CDK4/6 inhibitor, abemaciclib, for high-risk node-positive patients, with a press release coming up for the NATALY trial, which is a lower-risk population that may support the use of adjuvant ribociclib. So that is something that we're all anxious to hear. Hopefully, at ASCO, we're going to have some information about the NATALY trial as well. So let's first talk about the frequency of germline BRCA pathogenic variants in breast cancer. So this represents overall a small group of all of the patients that we see in clinic. Of course, you know, the first thing that all of our patients say to us when they come to us with a new diagnosis of breast cancer is, oh, I don't have any history of this in my family, or, I'm the first person in my family, and they automatically think that their breast cancer is on the basis of an inherited gene mutation, which in most cases is not the case. Only 5 to 10% of all breast cancers are related to inheritance of a high risk gene, like a mutation in in BRCA. But this risk or this incidence does go up in certain populations, as shown here, especially, in Ashkenazi Jewish patients. I practice here in South Florida, where we have a really high group or high incidence of Ashkenazi Jewish women. And then, of course, if we're looking at the incidence of the mutation in patients with ovarian cancer, it's a bit higher. And if we're looking specifically at triple negative breast cancer, it's 10 to 20% of all TNBC. So who should be tested? Well, I guess it depends on who you ask. And there are recommendations from a variety of societies. I've listed them here. American Society of Breast Surgeons put out a consensus statement in 2019 indicating that genetic testing should be made available to all patients with a personal history of breast cancer, whereas the NCCN guidelines are a bit different in that they indicate that testing should be based on personal and or family history. And I will say that the criteria for testing is being expanded by NCCN. And then, of course, there's the USPSTF 2019 statement that recommends against routine genetic counseling or BRCA testing for women whose family history is not associated with an increased risk for potentially harmful mutations in BRCA. So let's spend some time just talking about the testing from recommendations from ASBS and NCCN in a little bit more detail. So the first is that I mentioned that the American Society of Breast Surgeons recommended genetic testing to be made available to all patients that have a personal history of breast cancer, and that's recommendation 2 on this list. So these are bullet points from that consensus statement in 2019. You'll notice that they also mention a few other things with regards to who should be doing the testing and the education. In number 1, I'm not going to read it to you here. They also point out this issue of updated testing for patients who had previous testing. And in my clinic, I've been sending patients back to our genetic counselors as our testing techniques have advanced over time. If a patient was tested many years ago, we now have larger panels and even more refined ways of doing the BRCA testing. And I've had on occasion some patients picked up who were initially tested as negative. They do also mention that genetic testing should be made available to patients without a history of breast cancer who meet NCCN guidelines. And a word of caution that variants of uncertain significance are not clinically actionable. So how does that differ from NCCN? Well, again, NCCN puts this into 2 buckets: testing clinically indicated, and you see that here. It's based on a personal history of breast cancer with specific features, such as any woman with breast cancer at age less than 50, at any age, if that is to be used for treatment decision-making for a PARP inhibitor. Based on histology here, you also see any person with male breast cancer, or as I mentioned earlier, Ashkenazi Jewish ancestry can be tested regardless of age, or should be tested per NCCN. And then you'll notice on the right, it says any age continued, and there's this very complicated algorithm of how many family members and at what age they were diagnosed. And you know, this does become a little bit tough to follow. And in my clinic, you know, I'm certainly referring all of our patients to genetic counselors to help us make these decisions. NCCN also talks about situations where testing may be considered. And I'm not going to read you what's highlighted in the box on the top, but to summarize, they mention that a patient with a personal history of breast cancer and age less than 60 who doesn't meet any of the above criteria and may have a 2.5% pre-test probability of having a breast cancer gene could be tested. Now, how do you calculate that 2.5% probability of having a pathogenic variant? Well, you'll notice in the box there's a little Q superscript, so I would track that down and figure out, you know, how to calculate that pre-test probability. But fortunately, again, in my practice, I do have access to genetic counselors, and hopefully you all do as well, to help us make these more tougher decisions about whether or not patients meet criteria. And there are also other points that are summarized here on this slide for you as well. So now moving on to the OlympiA trial, which was a really important study. You see the study design here. Now, this is a trial that led to the approval of adjuvant olaparib for patients with BRCA germline mutation carriers that are high risk. And we're going to go through the eligibility in quite a bit of detail, but just looking on the left-hand side, again, these are patients with a germline pathogenic or likely pathogenic BRCA1 or 2 mutation. Notice that patients that were ER positive or triple negative were eligible. Again, they just had to have HER2 negative disease. These were patients that had stage 2 to 3 breast cancer, and there were 2 different groups. And we're going to go into this in the next slide. We'll do sort of a spotlight on the eligibility, but notice on a broad level, it included patients that had gone through neoadjuvant therapy. Also, you could have the patient go up front for surgery and have adjuvant therapy. Recognize that these are patients that had greater than or equal to 6 cycles of neoadjuvant chemo. And we're going to go through what type of chemo. You'll notice that the vast majority of these patients had anthracycline, taxane-based chemo. About 25% had even had platinum therapy. So we're not talking about the patient that went through 4 cycles of TC. That patient wouldn't have been eligible. This was a very large trial, an international effort, almost 2,000 patients randomized 1-to-1 to olaparib 300 milligrams twice daily for a year, or placebo. Notice the primary endpoint was invasive disease-free survival, and secondary endpoints included distant disease-free survival, overall survival, of course, safety and quality of life. So I mentioned we're going to focus a bit on eligibility, and I want to take some time to carefully go through this with you all, especially when we go through the cases that you submitted, because this is where it's important to go back to the trial and see if those patients in your practice that you're considering using adjuvant PARP, would they have been eligible on the trial? So again, these were patients that had either gone through neoadjuvant therapy or adjuvant. So let's focus on the neoadjuvant first. If the patient had triple negative breast cancer and underwent neoadjuvant therapy, they had to have a lack of a PCR, non-PCR. So patients with a PCR were not eligible if they were triple negative. If they had hormone receptor positive disease and went through neoadjuvant treatment, they had to have a considerable amount of residual disease. And that was categorized or accounted for by this scoring system called CPS plus EG. So what is this? It is relevant for hormone receptor positive patients who do not have a PCR, and CPS stands for clinical pre-treatment clinical stage and post-treatment pathologic stage. EG is estrogen receptor status, and tumor grade. Notice this is nuclear grade, not histologic grade. There's actually an online calculator that you can use to calculate your patient's CPS plus EG score. It had to be 3 or higher. So on a big picture level, I'll just point out that these were patients that had a significant amount of residual disease. They're looking for high risk patients that were ER positive. Again, I made this point, greater than or equal to 6 cycles of neoadjuvant chemo. If the patient went through surgery first and was having adjuvant therapy, if the patient had a triple negative tumor, it was basically any stage 2 or 3 patient. So we're not talking about the 1 centimeter node negative, triple negative patient. We're talking about a tumor size greater than 2 centimeters or lymph node positive. You were allowed to go on. If you were hormone receptor positive, the bulk of that disease had to be pretty significant, 4 or more positive nodes. So again, they're really looking for a high risk population here. Now, in terms of the characteristics of the patients that went on this trial, about 70% in both groups had a BRCA1 mutation, about 30% had a BRCA2 mutation. Notice the majority of patients, about 80%, were triple negative, but there were about 18 to 20% of patients that had hormone receptor positive disease. And as far as the patients that got on the trial via the adjuvant versus the neoadjuvant, it was about half-half. Recognize, again, I made this point earlier, these are all patients who virtually all had anthracycline and taxane-based therapy, 90% plus, and even about 25% had even had platinum, and that's illustrated here in the patient characteristics. Just a word on toxicity. For those of you who've used olaparib, you may be aware that this drug is associated with nausea. It does tend to happen early on in the treatment course. I tend to tell my patients to come back after 2 weeks on starting them, and I even schedule them for, a little bit of IV fluid supportive therapy in case they need it, and mention to them that that nausea seems to get better after the first, 4 to 6 weeks. You can also see some fatigue, some anemia, other GI issues like vomiting. You'll notice in this slide, you see the darker bars indicating the grade 3 or higher toxicity, and you even see the percentages of grade 3 or higher, fortunately quite low 9% grade 3 anemia, however. So this is something that we do have to be mindful of and make sure that we're watching for blood count issues, which can sometimes be pretty asymptomatic. So here we see the results of the invasive disease-free survival, which was the primary endpoint. The hazard ratio was 0.58. This translates into about a 40% risk reduction of having an invasive disease-free survival event. This was highly statistically significant. You see the absolute numbers. It was a 3-year IDFS rate, a difference of 8.8%. And what was really nice to see is that there was an improvement in distant disease-free survival. Here, the difference was about 7% between the two arms, and the hazard ratio of 0.57, again, about a 40% reduction in the risk of having a distant event. What was even more gratifying to see was the fact that these patients are actually even living longer. There was a 3.8% improvement in overall survival at 36 months. This was statistically significant. So the FDA in March of 2022 approved olaparib for the adjuvant treatment of adult patients with deleterious or suspected deleterious germline BRCA mutated HER2 negative high risk early breast cancer who have been treated with neoadjuvant or adjuvant chemo. Now we have this drug available, it's FDA approved, but we also have other therapies that we are routinely using. And now I'm going to go through some of those data sets and see how can we reconcile all of this information. So we're all familiar with the availability of adjuvant capecitabine for patients that have residual disease after neoadjuvant therapy. Recall the CREATE-X study was a trial that was done outside the US. It was for patients that had early breast cancer, stage 1 to 3B, and they had residual disease, non-PCR. They were randomized to capecitabine or control. About 30% of these patients had triple negative breast cancer, and 40% were stage 3A or B TNBC. What you see in the table on the upper right of the slide, and by the way, I just got back from Germany, from Berlin. I went this past weekend where I attended ESMO Breast 2023. It was a great meeting. And so this information is hot off the press in terms of the presentation. It's not new data, but really great presentations at that meeting. I encourage you to go online because all of it is available online. Dr. Sheba Irshad presented a really beautiful presentation on how to integrate all of these therapies. So you see here that there was an improvement in disease-free survival with the use of capecitabine, as well as an overall survival benefit in the capecitabine arm. And you see the differences broken down there specifically for the TNBC patients. I'm not going to go through too much this Japanese breast cancer scoring system, but again, it was done outside the US, and the take-home point that you see in that little plot on the bottom, when you kind of translate what scoring system they used was that the benefit was really in the patients that had significant residual disease, what we're calling RCB 3 or 2. And that's all you're seeing there at the bottom. So how do we reconcile this information, right? Because now we have capecitabine based on CREATE-X, and we have the OlympiA data that I just went through with you. Well, I will just point out that CREATE-X was not conducted in a setting of either prior carboplatin or checkpoint inhibitor intensified neoadjuvant chemo, which is what we're doing now. It was not focused in the germline BRCA mutated biological subset of triple negative breast cancer. Of course, there were these patients included, but I don't know off the top of my head how many, and they've certainly not been analyzed in terms of their responses specifically in the germline BRCA patients that participated on CREATE-X. I will point out that in the interest of time, we're not going to go through the metastatic data, but PARP has been compared to chemotherapy of physician's choice in the metastatic setting, and that was largely capecitabine in several studies, and we saw that PARP was superior there. Additionally, there's no combination adequate safety data. So what I mean by combination is that in a patient with residual disease, it is not safe to combine capecitabine and olaparib together. We have no safety data and no data to guide us in that way. So in my practice, if I see a patient in this situation who has residual disease and has a germline BRCA mutation, I would be erring on the side of offering them PARP over capecitabine. What about IO therapy? Many of us now for stage 2 and 3 triple negative breast cancer are utilizing the Keynote 522 regimen. This includes anthracycline, taxane, platinum, and a lot of chemotherapy plus IO in the neoadjuvant setting for stage 2 and 3 TNBC. And remember, there was not a second randomization. So if the patients had Pembro in the neoadjuvant setting, they were then went on to get adjuvant Pembro after surgery, regardless of whether they had a PCR or not. And what you see on this slide is the benefit. There's still an unmet need in the treatment of patients with no PCR following neoadjuvant chemo and pembrolizumab. You see that they still are not doing great. And so here, we also have to struggle with what to do in this situation. If a patient had neoadjuvant Keynote 522 and now in the adjuvant setting, you've gone ahead and committed them to that approach, should we be adding olaparib in that situation? Well, here is again an argument that Dr. Ershad made for and against combining PARP and IO therapy. So mechanistically, there is some sense that there is some synergy of combining PARP and IO in terms of upregulation of STING pathway and T cell recruitment, PD-L1 upregulation. We know that there is observed activity in combination studies in the metastatic setting that are illustrated in the table on the top part, and as well as the I-SPY neoadjuvant adaptive trial design, where we also have seen quite a bit of safety. The combination here appears safe. But against utilizing this approach is that we don't know if the relevance of this interaction mechanistically is it's unknown in micrometastatic disease, and we don't really know what the contribution is of PARP versus IO in this setting. Is it all just the PARP, and are we adding anything by giving IO? We really don't know. But so the way I approach this in my practice is in these patients that have Keynote 522 regimen and have a residual disease. Remember, I showed you even with Pembro, there's still a significant unmet need for those patients. I feel very safe to combine PARP with IO in that situation if they have a germline BRCA mutation. And then finally, what do we do about patients that overlap in terms of eligibility for monarchE? So remember, monarchE was the study that supported the use of adjuvant abemaciclib in ER-positive, HER2-negative patients. We now are seeing 4-year IDFS that is very good. The curves are remaining separate. We are now feeling really, really encouraged. Of course, there's no overall survival benefit here. And remember, we did go through the OlympiA data where there was an overall survival benefit, but here's some overlapping eligibility in terms of these high-risk patients. So what should we do? Again, in my practice, my preference would be to go ahead and use a PARP inhibitor. This is a very targeted treatment. The ER is not relevant to the mechanism. However, the ER positive HER2 negative subgroup, which was about 20% of the patients, did derive a benefit from adjuvant PARP. And remember, there's a survival benefit here. We have not seen a survival benefit with abema. Just in terms of sequencing, I will tell you that in terms of monarchE, patients were allowed up to 16 months after their initial treatment. So technically speaking, you could do the year of PARP and then sequence to CDK. There's no data to support that, but I certainly wouldn't combine them in a really, really high risk patient with a lot of residual disease, node positive, ER positive. Would I consider it? I guess that's like the kitchen sink approach. I would say the patient would have to be very highly motivated, and it would, of course, be a discussion. So with that, that comes to the end of the formal presentation. And now I have several cases that you all have submitted. I'm going to pause for a second before I go through these cases and just ask if anybody wants to ask a question, or should we just dive into the cases?
Reshma, I have a question. This is
Sure.
Chandra Bhimani. So I missed your point. If someone has a no PET CR, triple negative, they are BRCA and create extra. I don't understand which one you prefer. Combination of, or you will finish the 6 month of chemo followed by initiation of the PARP inhibitor.
So in a germline BRCA patient who has TNBC and who has residual disease, I would prefer to give that patient PARP. Now, if they had had IO as part of Keynote 522 in the neoadjuvant setting, remember there was in the Keynote 522 the adjuvant pembro that was given, regardless of whether they had a PCR or not, you're supposed to continue. There is safety data to combine them. So in that situation, I would feel very comfortable adding PARP and IO together in a patient that had residual disease post-neoadjuvant.
But you will not combine the Xeloda and PARP inhibitor together.
No, there's concern that there may be drug-drug interactions, cytopenias, and we really do not have safety data for that approach.
Okay. Thank you, ma'am.
Yeah. So anyone else with a question before we go through the cases?
Go ahead and go through the cases. I think a lot of the potential questions will get flushed out when you go through the cases, and then we can pick it up again at the end.
Okay, so these were cases that Charles sent my way, and I, in my usual style, I'm a highlighter type of person. I've highlighted the relevant points of the case. So whoever submitted this case, if they want to add anything to the information or clarify anything, feel free to unmute yourself and speak up.
Yeah, no, this is a Dr. Moravani. He can go ahead and present it.
Oh,
Yeah,
okay, great.
Yes, I'm here. Thank you, Dr. Mahadan. A great presentation. Learned a lot.
Thank you.
So thank you. And she's just seen a week or 10 days ago, very recent case. Came to me, just one visit happened. Here we are, 54-year-old, highly educated, postmenopausal female. She works in as IT tech in a local hospital. So mammogram previous year was normal, but current one showed 23 millimeter mass in the left breast, I believe, upper outer quadrant. And had a biopsy by the breast surgeon. It was positive, and then she chose an apparently left mastectomy before she even came to me. Had that done. PET was also done prior to that by her. It was negative. So the pathology from the mastectomy specimen did show 25 millimeter lesion, infiltrating ductal, grade 2, Ka67 around 22%. ER strongly positive, 90%, PR moderate, 50%, HER2 only 1+, no lymphovascular invasion, and there were sentinel lymph nodes, but 2 of them, I think, done well, negative, so did not have any axillary lymph node dissection. So she's technically stage 2, as we can see, T2N0, M0. There's significant family history of breast cancer in the sister at age 44. Apparently, her BRCA was positive, I was told. So the breast surgeon did test actually before even coming to me, and it was in the patient as well. It was positive, BRCA1. So good performance status, only history of hypertension, hyperlipidemia, or so. No any major comorbidities. So I was just looking into what would be your approach here apart from adjuvant chemoendocrine therapy.
Right. So this is a great case. Obviously, in terms of the chemotherapy decision making, I would send a genomic assay to help me make that decision. She is young. The Ki67 is over 20%. The tumor is over 2 centimeters. My pre-test kind of gut feeling is this woman is going to need chemotherapy, but I certainly would send a genomic assay to help me make that decision and also help encourage the patient recognize what her risk is. The point regarding the BRCA positivity, and certainly the family history goes along with that. I just, again, in terms of the spotlight on eligibility, I put this slide back up. So your case highlights an important question that has come up with regards to the OlympiA trial. What about patients that would not have been eligible? So I've highlighted here, your patient had adjuvant therapy up front, right? And her tumor was
Right.
T2N0. So in the ER positive group, she would have had to have 4 or more positive nodes to be eligible. Your patient would not have been eligible for the OlympiA trial. The bar for eligibility for ER patients, ER positive patients, was set very high, 4 or more positive nodes if they had adjuvant treatment, or if they had neoadjuvant, the extent of residual disease based on that CPS-EG score had to be significant. But it does raise an important question that biologically we struggle to say, why wouldn't it work, right? The patient still has a BRCA mutation, but certainly we just don't have the data here to support utilizing PARP. Would I bring it up with her? Sure. I would tell her that we have adjuvant PARP inhibitor available. She doesn't meet the criteria. I wouldn't certainly push her into it, especially if she's going to be getting chemotherapy.
Got it. Thank you very much. I appreciate it. Yeah.
Who had this case?
Hi, this is I had this case. So this is a 35-year-old lab technician who basically self-palpated a lump in her breast. And, it was a 3-centimeter lump confirmed on a mammogram and breast MRI. There was one positive axillary lymph node on palpation. And the biopsy was consistent with the infiltrating ductal carcinoma. It was triple negative. So, at that point, we talked to her about the neoadjuvant approach. And she had completed a childbearing. So, we kind of skipped that issue. She was tested and she was BRCA1 positive, but that sort of happened while she was getting treated on the Keynote 522. She went to surgery and had a complete pathological response. So I still have to see her back post-operatively. And
Yeah.
Yes.
So great case. Again, I've brought us back to the spotlight on eligibility for your patient. So to summarize, this is a patient that had a clinical T2N1 triple negative tumor, and fortunately had a very good response. She had a complete pathologic response. Again, focusing on this group, the neoadjuvant patients that had triple negative breast cancer, they had to have residual disease. I actually went back to the paper to see if they commented on a certain threshold. You have to have a centimeter or so. I didn't see it. So any amount of residual disease would have qualified your patient to participate on OlympiA. But fortunately for her, because she had a pathologic complete response, her prognosis would be better and she would not have been eligible for the study. It's surprising, and you do feel, again, as we struggle with where are the unanswered questions here, are we able to do anything better for these patients? Because we know that even some patients that do have a PCR do end up relapsing. They're small numbers, but they do occur. Again, we just don't have the data because they were not eligible for the OlympiA trial. So I would do what you're doing. I would go ahead and continue the Pembro. Even there, I struggle with, are we really doing anything for those patients by giving them the adjuvant Pembro? Can we drop it in the patients that have a PCR? Again, we don't have data. In Keynote, there was not a second randomization. So if you were randomized to the Pembro neoadjuvant, you got it in the adjuvant setting, whether you had a PCR or not. And that's what I would do here.
There is no data on combination of Pembro and the olaparib, right?
So we had gone through that. Again, there are safety data to combine Pembro and PARP inhibitors in the metastatic setting. It is safe to do so. And in a patient that had residual disease, there would be where I would be looking to combine them both. But because this patient achieved a complete pathologic response, she would not be eligible to receive adjuvant PARP per the OlympiA trial.
So then you are starting the olaparib right at the time when the Pembro is getting started in the adjuvant setting, correct?
And we certainly have safety data to combine PARP and IO, so I don't have any concerns there.
I have a quick question. When these patients are started on the PARP inhibitor and they are also on immunotherapy and they start having like cytopenias or nausea and all that, how do you decide what to do next?
Yeah, that's a great question. I will say that if you look at the Keynote 522 toxicity profile of the Pembro part, you do see that the toxicities during the adjuvant portion of the treatment was much less than when they were on the neoadjuvant IO and chemo. So I have not been in a situation where I've seen patients suddenly develop nausea or worsening toxicity to IO therapy while they're off of the chemo. It seems like a lot of the toxicities are amplified when they're on chemo. Certainly, if you have any concerns about overlapping toxicities, there wouldn't be a downside to giving them a few cycles of the adjuvant Pembro and then starting the PARP later, 6 weeks later or something of that sort, and that would help you kind of clarify what's going on.
Thank you.
Sure. So let's go to this case. Oh, Neeraj, I think you're on mute.
Okay, so this is just a general question. So the drug was approved last year, and we have some of these patients, who want to do everything possible. So this was like late 2021, and then she was treated with neoadjuvant, and she's ER positive, so she may not technically qualify for PARP inhibitor at this time. But I just so I do have other patients who maybe TNBC want to do anything possible. So if they're already 1 or 2 years out of their adjuvant therapy, shall we go back or add more?
Again, great. So just in terms of if we knew that this patient was BRCA positive, I mean, here I've highlighted your question on the bottom. Do we check for a BRCA mutation at this stage? Well, I don't have any information about her family history and things of that sort, right? Because again, NCCN for patients that are over age 50, it's very much dependent on family history as far as whether they're eligible for testing or not. According to the American Society of Breast Surgeons, this patient has a personal history of breast cancer and would therefore they would advocate that she should be tested. According to NCCN, we would need to know if she's of Ashkenazi Jewish ancestry, what her family history is as she's over 50. So in a situation that she was tested, say for example, and she was BRCA positive, I would say she would likely not meet eligibility criteria. Again, here we would have to characterize the CPS-EG score. Now, she did have neoadjuvant therapy. She had residual disease, but you mentioned here it was a small amount of residual disease, T1C and microscopic involvement N0I positive. Of course, I would still go through the trouble of calculating the CPS-EG score. That pre-treatment stage may drive up that score because remember, she had a very large area. It was a T3 lesion, but with the amount of residual disease, my suspicion is that she wouldn't qualify. And then in terms of your last question, as far as, 2 years out or so, should we be checking and then starting PARP, in a delayed fashion? Again, we just don't have the data to do that. As we're looking at the data that we have, I'm very much, a purist in terms of following what the trial did in terms of eligibility, post-surgery, how many weeks they had to go on, and starting it during that time period. Fortunately, we talked about toxicity, and we didn't talk about the toxicity that we were all very concerned about, which was MDS, AML. Fortunately, we did not see hints of that. But still, from a quality of life standpoint, it does have some toxicity. You might end up needing a transfusion and things of that sort. So I certainly wouldn't want to willy-nilly start going back and testing people years out. So I wouldn't do that. This is the last case.
Hi, so this is my case. We had a 49-year-old that came to us. She found a lump in her right breast. She had a mammogram that showed a 2.5 centimeter mass, had an axillary ultrasound that was within normal limits, as well as a normal, at the time she had an MRI that was pending, and then she finally had it, and it pretty much confirmed. When she had a biopsy, it showed that she was triple negative. We sent her right away off to the genetic counselor, got tested, she was BRCA2 positive. We also referred her to GYN at that time as well. She received neoadjuvant Pembro carbotaxol, followed by AC, and then Pembro as well. She opted for a bilateral mastectomy as well as a BSO. She had no residual disease and 2 negative nodes. And my provider and I both, he decided to put her on adjuvant Lynparza. Her ANC dropped maybe the first or second month in, but she continues to be on the adjuvant Lynparza. She developed some mild macrocytosis. I did work up, and everything's been normal, and she's doing well, and we're closely following her.
Yeah, so a few comments on this case. This is a situation that I think we struggle with in terms of offering all of the treatment that she got in the neoadjuvant setting. Certainly, very appropriate. She would have been eligible for Keynote 522. She has a tumor that's over 2 centimeters. It's triple negative. It was node negative, presumably. I see an axillary ultrasound was within normal limits. So at the time that she had her surgery, she had no residual disease. It's interesting that, it does say, I missed it. I didn't highlight it. It does say adjuvant Keytruda. I missed that part because I was going to ask if she got adjuvant Keytruda. So she did appropriately go on to receive those 9 cycles of adjuvant IO, even though she had a PCR. Again, this patient technically would not have been eligible for OlympiA because she did have a PCR. So patients that had triple negative disease, for them to go on, they would have had to have residual disease. She seems like she is tolerating it reasonably well. I mean, her counts are a little bit low. This is getting back to that question that we brought up. What do we do about patients that weren't eligible? Biologically, we struggle with this to say why it wouldn't work, but we just don't have the data to support using PARP in a patient that wouldn't have been eligible for the trial.
Really selected out the highest risk patients, and the majority of patients that are getting seen in clinic are not going to fit these criteria.
True. And that's, the situation that we're dealing with. I think that there are a lot of questions that came up with regards to the OlympiA data. The biggest one in my mind is it highlighted the importance of testing. Should we be following the surgeon's recommendations of testing everyone? Previously we were using the testing to inform the risk of further cancer, preventative strategies, surveillance, but now we're using it for a treatment decision. So I think one question that comes up quite a bit with the OlympiA trial is, should we be testing everyone? Then the second question that comes up that we've dived into a lot in the context of these cases is, where do we draw the line? Are we going to be very rigid and only include patients that were included in the trial? What about patients that weren't eligible? The other question that comes up is the duration of adjuvant olaparib. Is 1 year the right duration? Can we get away with less? I mean, those curves started to separate early. They stayed separated? Do patients need that full year? I mean, we have a lot of questions that remain unanswered, but it was still a very important study that is now leading to the ability to at least reduce risk substantially in these high-risk patients with the germline mutation.
Is there an ongoing trial for lower risk patients?
Not that I'm aware of.
Interesting. Does anybody have any questions they'd like to ask?
Reshma, I have one question. This is
Sure.
Chandar.
Hi.
So 5'2" and 2 centimeters above, how you are choosing versus dose dense ACT?
Hmm.
How you are making a decision? And is it all anybody who's more than 2 centimeter triple negative gets 5'2" regimen?
Yeah, so the patients that I am considering for the 5-2-2 regimen are the ones that are stage 2 or 3. I practice in South Florida, so I do struggle because sometimes my patients are older, and if they have a 2.1 centimeter node negative, triple negative breast cancer and they're 80 years old, do I really think that they're going to get through all of that chemo and IO? In those situations, I have started just with the platinum and the taxane, and if they have a very good response, I have not gone on and given them the AC. There's also data to support Toxicity and carboplatin and IO. Priyanka Sharma published on that for 6 cycles. It was called the NeoPact trial. It was a small phase 2 study, but still lends some support. In the situation where patients are getting the anthracycline and are felt to be appropriate, remember in Keynote 522, it was given every 3 weeks, and that's where we saw the responses that were reported out and led to the approval. So you can't really argue with success. In my practice, I'm following how they did it in the trial. I think it also helps to kind of line up when you give the IO with the AC, because it's every 3 weeks. Although I will tell you, I share several patients with physicians at Memorial, and I've seen them do the AC every 2 weeks, dose dense, and then they give the Keytruda at the 6-week dose, so it still matches up. But I feel that it's really hard to do it because it's a lot of treatment, especially in a patient that, they're almost living in the cancer center. They're there every week with blood count issues and everything else. Dose dense is pretty hard.
Got it.
So are you just omitting in the some patients that you may think that they're not appropriate for anthracycline, you're just using like Dexotier, IO, and
Carbo, or I've just given the Keytruda carbo taxane portion of the Keynote for the 12 weeks.
Okay.
And then I've just not, if they on clinical exam and by imaging, if they're doing really well and they're older and I don't really feel like they're going to get through the AC, I have stopped the neoadjuvant treatment early and taken them to the OR. Of course, that's not ever our goal. We prefer to follow the recipe, so to speak.
And then, I have another, patient that has like a T1 lesion, right? Like a 1.9 centimeter though. Okay.
I know.
And N0, right? So of course, no neoadjuvant, taken for surgery, lumpectomy doing great, so got adjuvant TC, right? So, adjuvant, when I was deciding, I'm like, should I add pembrolizumab, or should I try to give, olaparib, after the 4 cycle? So that's the, so I don't know how.
She's BRCA?
Yeah, BRCA positive, yeah.
Yeah, so she's BRCA positive, and she had adjuvant therapy, and she had a triple negative tumor. If it was T2 or greater, how big did you say it was?
1.9, so almost T2.
Yeah. So, that's where I would probably push it a bit and say, okay, biologically, is there really a difference between a 1.9 and a 2 centimeter tumor? Yeah. I would probably offer that patient adjuvant PARP. The question about the IO in the adjuvant setting alone, that's a tougher one, right? Because we just do not have any data to support giving just adjuvant IO. There are ongoing trials like SWOG 1418 and other studies that are going to help try to tease out what is the contribution of that adjuvant portion of the IO to the responses we're seeing? Right now, we just don't know. So in my practice, I'm not routinely giving IO in the adjuvant setting to patients that have not had it as part of their preoperative treatment.
Yeah, no, that makes sense. Yeah. So
But I would probably give
told
your
the patient that,
patient
you know,
part.
the Limpaz is going to probably make a much better difference than IO, especially
Yeah.
when it's the BRCA driven.
Yeah.
So I think I said, let's finish the TC and then,
Yeah.
do the Limpaz after that. Yeah.
But the problem is when you start saying, oh, okay, 1.9 is close enough to 2, it starts to become a slippery slope. So then
Yeah.
it's
There's like,
1.7.
how about
close enough
how about
to 2.
1.8, you know, then the next
How
is
about 1.8? How about
Yeah.
1.4? I mean,
Yeah.
where do we end? I don't know.
Yeah, I know that. So, and then another thing is, you know, as soon as the insurance will see that it's T1C, they may just decline it also. So that's what I said, you know, the insurance approves it, you know, we'll go ahead. Otherwise, you know, we'll watch you kind of stuff.
Yeah, and also, you know, it also depends on how you stage it based on, like, if you see on the MRI, if the MRI showed a different size than the initial mammo, sometimes after the biopsy, the MRI shows some post-treatment changes and the measurement comes out a little bigger. So
Yeah, no, it's hard to call. And then another thing is, how much are you worried about, you know, and it's a shorter duration compared to ovarian cancer, but how much are you worried about like the bone marrow disorders like MDS and, you know, those things that are kind of brought up with just 1 year of treatment, especially if they're getting anthracycline also, right? I mean, it's a very valid concern, especially if someone is 35-year-old, you give them anthracycline and then you give them Limpaz, kind of, you know, so you kind of do worry about that, you know, at the end.
yeah, and that's kind of the counter argument to just using it outside of the group that it was tested on, because obviously, you know, in the clinical trial, we didn't see any signal that we were increasing the rates of AML or MDS. But I mean, there have been cases where outside of the study, you know, post-marketing, you see numbers that are higher than what you saw in the trial. And I wouldn't rest easy saying that, like, I mean, we know it can happen. So how awful would we feel if we pushed the boundaries and gave a stage 1 BRCA positive patient who wouldn't have been eligible to participate on OlympiA, you know, the year of olaparib, and then she developed MDS.
Yeah, that would be very shameful.
Yeah. So, I mean, this is why we have to be, I think, very thoughtful in just expanding the indications beyond where it was studied, because we just don't know, you know, in these lower risk patients, are we exposing them to a risk?
Reshma, can I just ask a general question about
Yeah,
triple negative? So if you have an older, let's say 80+ woman with let's say a 2.2 centimeter triple negative breast cancer, no BRCA mutation, would you ever in the adjuvant setting consider giving her CMF?
Yeah, I have actually used a lot of CMF in that situation. There was a Canadian study that looked at anthracycline versus CMF, and actually there was some hint that in the triple negative patients there might have been some superiority to CMF. I mean, but in the situation of these older patients, which, you know, I see quite a bit in my practice, it really becomes a consideration of competing causes of mortality. I mean, if you see someone who's 80 years old and has diabetes, cardiovascular disease, all of these other issues, and you might end up hurting them more than helping them. What is their life expectancy? If you think it's at least 5 years, then of course, you know, we think about treating those patients. We know that TNBC can be aggressive, but you know, those are tougher decisions, and I certainly am not giving those patients anthracycline. So CMF or TC, I think, is a very reasonable treatment in that situation, if they're suitable for treatment.
Thank you.
Thank you, Dr. Matani, for a wonderful presentation, and for those of you that brought your engagement and the great cases for discussion. Until next time, I hope everybody has a pleasant night.
Great. Thanks, everyone. Have a good night.
Thank you. Thank you.